Okay, I will be presenting on irritable bowel syndrome. Okay, today I'll be presenting on irritable bowel syndrome. So to begin a normal GI exam, I would collect subjective data, do the review of systems, starting with constitutional information, focusing on any changes in weight, fevers or chills, or changes in appetite. For HENT, I would want to know if they've had any difficulty swallowing. For GI, I would want to know if they've experienced nausea or vomiting, heartburn, abdominal pain, bowel movements, if they've been constipated or if they've had diarrhea, what the color of their stool is, if they have hemorrhoids, and what their flatulence patterns are. For GU, I would want to know about urgency and frequency of urination, the color of urine, any recent infections. If they're female, does their abdominal pain correlate with their menstrual cycle, and is there a chance they may be pregnant? I would inquire about their past medical history, any allergies, current medications, or recent infections. I would want to know if they've had any other GI studies completed and what their family history of GI conditions consists of. For pertinent subjective inquiries for patients with IBS, I would go through old cards. I would want to know what they were doing when they first noticed symptoms, including their stress levels, where the pain's located, how long they've had the pain. If they've had it for a while, why did they come in today? I would want to know the characteristics of their pain, knowing that cramping is indicative of bowel disease, while sharp pain indicates ulcers. I would want to know about any triggers, including foods, medications, stress levels, or positions. If they've had anything that's helped with the pain, primarily if defecation relieves the pain, what medications they've used to treat this, if any, and how much is this interfering with their life. The clinical presentation of IBS consists of a history of abdominal pain that's relieved with defecation. They notice a change in the frequency and appearance of their stools. Stools can range from less than 3 per week to more than 3 per day. They have more than 3 per day, that's IBSD. If it's less than 3 per week, it's IBSC. If they do have formed stools, they're often small and pellet-like or narrow and pencil-like. Abdominal pain or fullness is a distinguishing feature of IBS. It's not typically present with traditional constipation. They may also feel like they've had incomplete evacuation, bloating, flatulence, clear and white mucus with stool, and occasional fecal incontinence. Their symptoms are likely going to be exacerbated by stress. Left lower quadrant abdominal pain is often made worse by eating, but passing of stool or flatus can be relieving, and their physical exam is often normal. The patient may have some left lower quadrant tenderness or abdominal distension. Gastrointestinal exam will have the patient in the supine position, make sure that they have emptied their bladder and that the skin is exposed over the abdomen. We'll begin by inspecting the abdomen, noting any abnormalities in contour, and then assessing the skin, looking for old scars that may indicate a previous abdominal surgery. We will then auscultate for bowel sounds. We'll begin in the right upper quadrant, moving to the left upper quadrant, the right lower quadrant, and then the left lower quadrant, knowing that normal bowel sounds occur 5 to 30 times per minute. We'll listen over the liver, noting for any friction rubs. We will do the same thing on the left-hand side for the spleen. We will then listen for bruits over the aorta, listening to the renal arteries, the iliac arteries, and then the femoral arteries. Following auscultation, we will begin percussion. We will percuss in all 4 quadrants, expecting to hear tympany. And then we will assess the borders of the liver by beginning in the right lower quadrant, working from an area of tympany to dullness, marking that spot, and then doing the same thing, starting in the lungs, moving from resonance to dullness, marking that spot, and expecting the liver to be within 6 to 12 centimeters. We'll do the same thing on the left-hand side for the spleen. We expect air dullness, and then have the patient take a big deep breath in, and it should change to tympany if the spleen is not enlarged. Following percussion, we will begin palpation. We'll start with light palpation in all 4 quadrants, noticing any grimacing that the patient may be doing that could indicate pain. And then we will move to deep palpation, starting in the right lower quadrant, Moving our way up to the right upper quadrant, feeling for the margin of the liver, can use the hooking technique underneath the patient's ribs here. We'll move over to the left upper quadrant, assessing the spleen and knowing if the spleen is palpable, that means it's enlarged. And then the left lower quadrant, we're palpating the sigmoid colon, which can be tender if there's stool in it. And the tender sigmoid colon is a normal finding in a patient with irritable bowel syndrome. We can also palpate the inguinal lymph nodes, noting any pain or tenderness here and feeling for any swelling. We will also palpate the kidneys, noting any abnormalities here. And then to assess for a possible kidney infection and flank pain, we would ask the patient to sit up and tap under the costovertebral angle, assessing for any pain or tenderness. Risk-specific considerations for IBS include being of female gender, less than 50 years old, having mental health conditions, or a family history of IBS. Other comorbidities like fibromyalgia can also increase the likelihood of having IBS. Differential diagnoses, there are a bunch, but the primary ones are Crohn's disease, ulcerative colitis, or celiac disease. And here are my references.